Hi, everyone. I know people are still joining from the waiting room, so I'm going to give everyone a couple of seconds to log in. Okay, we're going to get started. Thank you all for joining us today. My name is Caitlin Thompson. I'm a psychologist at the Kennedy Krieger Institute here in Baltimore, Maryland. I am one of the Education Committee co-chairs of the FNSD SIG, along with Dr. Richa Aggarwal Dutta, who's here as well. So we want to thank you for joining our third webinar since the FNSD SIG started. And today we have the pleasure of being joined by my colleagues here at Kennedy Krieger Institute. So we're going to have a multidisciplinary panel and case discussion. So I'm going to take a moment to just introduce my colleagues. So from neurology, we have Dr. Shannon Dean. She's a pediatric neurologist with a subspecialty training in movement disorders, and she became interested in functional neurologic disorders during the TikTok pandemic during COVID. And she is one of the co-founders of our FNSD multidisciplinary clinic here at Kennedy Krieger. So welcome, Dr. Dean. We also have Dr. Souraya Torbey, who is an assistant professor in psychiatry who specializes in chronic pain and FNSD. And she, along with Dr. Dean, is one of the co-founders of our FNSD multidisciplinary clinic here at Kennedy Krieger. So thanks for joining us, Dr. Torbey. And then we have Jenna Werner, who is a physical therapist who has worked in several of our outpatient multidisciplinary clinics and on our inpatient neurorehabilitation unit at Kennedy Krieger. Jenna specializes in working with individuals with chronic pain and FNSD, as well as other functional and neurological disorders. And currently she works as a physical therapist at the Kennedy Krieger School. So welcome, Jenna. We have Nicole Andrejow joining us. She is an occupational therapist who works with patients with chronic health impairments in our intensive interdisciplinary outpatient rehabilitation program here at Kennedy Krieger. Nicole has worked with her colleagues to develop a clinical protocol and to analyze outcomes to continue to provide evidence-based interventions. So welcome, Nicole. And last but not least, we have Karli James, who is a certified therapeutic recreation specialist with nearly 8 years of experience in child life and therapeutic recreation here at Kennedy Krieger. She specializes in providing recreational therapy services on our inpatient neurorehabilitation unit, focusing on patients admitted under our chronic pain and functional disability, brain injury, and spinal cord injury services. So welcome, Karli. So we are going to kind of go through and have our team members talk about their role in working with youth with FNSD. And then we are going to have a case discussion and some time for questions and answers. So if you have any questions during the presentation, please put them in the Q&A box. And then we're going to be monitoring that, and we'll save time at the end to go through some of the questions. Okay, so we don't have any disclosures as a team, and we're going to start off with Dr. Dean. So Dr. Dean, take it away.
All right, thanks, Caitlin. So my name is Shannon Dean, and I'm going to talk to you first about the role of neurology in this clinic. So the things that I do in this clinic is, first, I'm the one that usually makes the diagnosis. If there's a concern about any other disorders being a potential confounding diagnosis, I do a focused workup as needed. And then the last thing I do is I explain the diagnosis, and I explain it in a way that's positive for the patients and that sets them up to hopefully accept the diagnosis and then sets them up for success in therapy. Next slide. Usually when I'm talking about functional neurologic disorders, I'm talking to audiences about what it is. In this case, I'm more talking about what I do. But it does, you know, interact with the fact that there's been some big changes in how we diagnose this disorder. So as many of you are aware, previously you needed to find a direct trauma or stressor that patients were converting into their symptoms. This was back in DSM-4 when conversion disorder was the primary diagnosis, and functional neurologic disorder was just starting to be used as terminology. In the DSM-5, as you all know, we no longer need to identify a trauma or a stressor, and instead the emphasis is on positive signs and symptoms in the neurologic exam that are specific for functional neurologic symptom disorder. In other words, we've moved from merely absence of evidence of organic disease to increasingly being able to look for specific things that say that this is the diagnosis. Next slide. So the things that I'm looking for in the history are a story where the symptoms started after a relatively minor illness or injury, not expected to cause neurologic damage. So things like it started after a minor car accident, it started after I had the flu, things like that are common stories that you will get, or abrupt changes in the symptoms. Well, it started with a leg tremor, but then the leg tremor stopped, but then the leg became paralyzed, and then she was able to walk again, but then she started to have these seizures, things like that. Other things that aren't as specific but are suggestive are things like the symptoms worsening with stressors. Of course, other neurological illnesses can do that, but it's usually to a greater degree in functional disorders, and family members or personal history of other neurologic symptoms. So people who have epilepsy are at increased risk of having seizure-like attacks, for example. Not that every patient with epilepsy has that, but they're more likely to have it than the general population without epilepsy. Next slide. There's other similar clues on the neurologic exam. So in this case, a lot of what I'm looking for is distractibility. So the symptom stops when the patient is not attending to it, and suggestibility. The symptom becomes much worse when the patient is attending to the exam, is aware that I am looking at that body part. More specifically, you'll often see a mismatch between confrontational and functional testing. So that means when we're formally testing leg strength, you know, we're having them press against our hand. They're not able to bring much strength to bear, but they are able to use those same muscles that couldn't do anything for them when they were thinking about it with automatic movements like shifting on the table or things like this. This is also what the classic Hoover's sign and adductor sign are relying on. And then inconsistency, finding that the symptoms switch muscle groups, or if it's a tremor or something like that, it changes the position that it's moving in, it changes speed, it changes you know, other factors like that. Other things that are suggestive but aren't as specific as those other three things are things like effortful production of movements. So a lot of huffing and puffing and grunting during the exam, and then exaggerated startle on reflex. So they have the actual reflex, and then a second later, they'll have a second jump. You know, you can kind of almost see it go all the way up to the cortex and then back down as a startle. Next slide. So the next thing I do once I have done my exam and done my history and decided that the diagnosis is appropriate is I decided.
Dr. Dean, you just unmuted really quickly. If you
Oh, there we go. Sorry about that. In FND, it is important that any diagnostics are focused on legitimate alternative diagnoses when you're not 100% sure. So patients with seizure-like attacks, often, you know, there are some seizures that can fool you. So if it's feasible, we like to capture that on EEG, or, you know, a patient with weakness where most of the exam indicates a functional problem, but there's some asymmetry in the reflexes, things like that. Those are patients that do require a little bit more workup. If the leading suspected diagnosis is FNSD, whatever workup we're doing should be phrased in such a way that we expect this workup to be normal, that we are ruling out things that would be more serious, but that we think are unlikely, and that a normal result is both reassuring and expected. And if the exam is completely reassuring, the features are classic, you've got a lot of nice, specific, positive features, you may not need to do any workup at all. So the big thing here is to not get stuck in a loop of a fishing expedition where you're looking for more and more things and the patient is getting more and more worried as all of these tests come back as normal. Next slide. So the next part of this is explaining the diagnosis to the patients. And when we do this, we need to move from the idea of neurologic disorders as a lesion-based disorder. You know, that's a lot of what neurologic training is on, right? We're looking for where the bridge is out. We're looking for where the stroke could be, or where the MS lesion could be, or things like that. When we're talking about disorders like FND, there's no lesion defined. The bridge is not out, the road has not collapsed. Instead, we're looking at a hardware system that's basically intact, but what we've got is a problem of function due to networks of activity rather than due to, you know, a destructive lesion. Slide. So I do talk about the neurobiology of FND with our patients. So we talk about the networks that we know are involved. I talk with them about the fact that we think that this is a multi-network problem. And I talked with them about the fact that fMRI studies, for example, have demonstrated that there are abnormalities in signaling in the limbic network and the salience network in these conditions, and that these abnormalities, for the most part, normalize after successful completion of therapy and after their symptoms have gotten better. I'll often explain this by talking about the idea that you know, these disorders are often involve areas of the brain that process the parts of survival that are unpleasant, things like fear, pain, anger, sadness, vigilance, fight, flight, and that these systems are supposed to be able to take over in an emergency. They're supposed to be able to change what you pay attention to, change your motor output, change how you perceive sensory input. But what's happening in FND is these survival mechanisms have basically started to run amok, and they've started to send out inappropriate signals. And part of how we get people back to functioning is we start to, you know, fight those reflexes, start to habituate out of those reflexes and calm down that network. Next slide. So explaining the diagnosis is actually the first step in the treatment of FNSD. So how I do that is during the exam, I will demonstrate positive findings on the exam to the patient, and I'll refer back to those when talking about the diagnosis. And then I'll review the different types of neurologic signs and symptoms and how they point to symptoms that are due to injury, are lesion-based problems, versus symptoms that are due to a network problem, due to a more complex reflex. And this is where I talk about the hardware versus software problem. I emphasize the positive features in their history and exam that point to the diagnosis, as well as things that point away from the alternative diagnosis. And that gives patients confidence that it's not just that we don't know what's wrong or that we're missing something, but that we do know what's going on, and it's something that is pretty treatable and pretty reversible. I'll briefly explain what we understand about the physiology of functional disorders, talking about amygdala hyperactivation and about how that hyperactivation is reversible. And then I'll emphasize that with therapy, the prognosis in young people with this disorder is excellent. And then the next part is using our multidisciplinary team to start getting people to function again. And that's it for me. The reality is we know that not all neurologists know how to talk to their patient about this disorder. Some neurologists and other health professionals confuse functional neurologic disorder with factitious disorder. So they think that patients are faking it either to gain attention or to get out of something or to gain access to something. And even when that's not the case, when you've got providers that are the first point of contact that are more comfortable with these disorders, often patients are presenting in an inpatient or emergency setting where there's not enough time to have this kind of long, detailed conversation with patients. So this means that even if the diagnosis has previously been made, re-explaining this disorder from a neurologic perspective can undo some of the damage that may have been done with that initial encounter with the medical system, and can in and of itself be therapeutic. And now I think I'm done.
Thanks, Dr. Dean. We are going to move to Dr. Torbey to discuss the role of psychiatry. Oop, Dr. Torbey, you need to unmute.
They're muting me.
Oh, got it. Sorry, we were using her audio. It's okay.
There we go.
Can you guys hear me? Oh, hang on. I need to put my speakers on. Sorry, guys. Can everyone hear me now?
You're good.
Okay, thank you. Okay, so thanks for the introduction, Caitlin. So my name is Souraya Torbey. I'm the director of the Integrated Care Clinic at Kennedy Krieger and the co-director of the FNSD clinic with Dr. Dean. Thank you so much for having us today. I'm so excited that there are so many psychologists and folks who are interested in FNSD. We definitely need a lot more people. So I'm going to just start it off really quick by showing this painting by Pierre-André Brouillet, which shows Jean-Martin Charcot with his patient at Pitié-Salpêtrière in 1887. This painting shows like our conceptualization of FNSD. We've come a long way from this conceptualization. At the time, we recognized it as hysteria. There have been a lot of different conceptualizations for functional neurologic symptom disorder. Next slide. We have viewed it in the past, it's been viewed as a supernatural process. Hysteria, which was a wandering uterus. Obviously, yes, of course, it only happens in women. So it must be a wandering uterus. Conversion and dissociation, cognitive and neurocircuitry models, which is a little bit more recent. So there have been a lot of different conceptualization of FNSD. And like Dr. Dean said, I'm not going to go into the details. We've come a long way from how we used to think about it. And this is something that we definitely is a big part of our work in psychiatry and psychology is recognizing that the patient, when they're given the diagnosis, their mind may go to those other conceptualizations. So our role is to kind of restructure that type of thinking. Next slide, please. Okay, so I'm going to start off by saying that a psychiatrist's role is very different in consult liaison than outpatient psychiatry. I'm going to start off a little bit in the consult liaison role. Next slide. So it's very important to involve psychiatry early in the process. And it's important for a couple of reasons. It's been shown to actually improve family engagement and decrease the length of stay in the hospital. Even before, we want to get involved even before all medical workup gets completed. Next slide, please. So until a few years ago in 2019, we really did not have much guidance over how this process needs to occur, how we need to evaluate patients, how we need to address like the transition from inpatient to outpatient, until this paper came out by Ibisiaco 2019 by my colleagues on the Critically Ill Child Committee at ACAP. And we really use this pathway pretty religiously at Johns Hopkins. We want to start off by educating our fellow specialists and in terms of recognizing somatic symptoms. And here we're going to focus more on functional neurologic symptom disorder. We want to make sure that we're educating pediatricians. So we do a lot of actually lectures and educating our pediatric fellows in regards to recognizing somatic symptoms and recognizing functional neurologic symptom disorder. So early recognition is key, obviously, because it starts off the entire process of the treatment plan. Then we also want to start off with early interdisciplinary assessment. We want to get involved we want to involve psychology, psychiatry, want to involve physical therapy when needed, and all the other specialties. So we want to convey to sometimes if it's the pediatricians, and obviously not all hospitals have such an awesome neurology team as the one that we have. We want to make sure that we're helping our fellows and the other specialists recognize those symptoms. So, and helping them recognize them and then consult the correct services. Then we move on to interdisciplinary provider meeting. So this is where we're involved. We're recognizing that there might be some somatic symptoms. We're recognizing this might be functional neurologic symptom disorder. We need to sit down as a team and talk about our suspicions about it. Next slide. So let's say SSRD in here is functional neurologic symptom disorder is recognized. We move on to the interdisciplinary informing the family meeting, which is a big part of our role. We want to be involved in explaining the diagnosis to the family. We want to be involved in stressing out that misdiagnosis is quite rare and happens only in 4% since the 1970s. And we want to encourage all primary caregivers to be present for the diagnostic discussion and go over the neurobiology and psychological underpinnings of the diagnosis that Dr. Dean already went through. And the next step is the interdisciplinary management during inpatient hospitalization. Part of our role as psychiatrists, obviously, is to recognize other comorbidities. We want to help the patient and the family start shifting into demedicalization of symptoms and focusing more on rehabilitation and increasing in functioning. And then our role as a consult liaison is really playing a huge role in setting up outpatient care and in terms of both medical and in terms of therapy to assist our colleagues. Next slide. So really the consult liaison role is to early recognition, being involved at the beginning. We've kind of shifted our thinking. We have been more involved as a consult service now because we've had a lot of lectures with other services. And with our colleagues in neurology, obviously, it's pretty seamless now. Interdisciplinary management, working with the teams closely, especially sometimes reinforcing that this is what we think it is. We think it's functional neurologic symptom disorder. I have had a few patients that I have cognitive symptoms that I was pretty convinced were FND, and I had to have in-depth discussions with pediatricians and other specialties, reinforcing the importance of treating the mental health part, introducing the biopsychosocial approach, and then our presence in provider family meetings when we discuss the diagnosis. Next slide. Our role as outpatient psychiatrists is quite different. So as an outpatient psychiatrist, seeing someone with functional neurologic symptom disorder for the first time, we definitely want to evaluate and assess. We want to identify psychiatric comorbidities, whether they're present or not. We want to make sure that we provide the psychoeducation, but our biggest role obviously is management. Next slide. So as an outpatient psychiatrist, one of our biggest role that I really stress with our fellows is being the point of reference. We need to take on that role of the primary care physician. So in almost most things, the primary care physician is the point of reference, but a lot of times with somatic symptoms, the psychiatrist needs to become the point of reference. So this takes a lot of coordinating, and a lot of my patients with functional neurologic symptom disorder tend to see a lot of different specialists and try to get second opinions. So what I try to do is get releases and get all these different specialists, including obviously the therapist or psychologist, on the same thread on email, so that we are all being updated whenever something is coming up, and we are all conveying the same message and on the same wavelengths. So this is a big part of our role. The other parts of our role, and I know other folks are going to talk about it, is obviously being involved in the behavioral plans in terms of school, at home, communicating with the psychologist and coordinating that, and working with and obviously working with the other specialties. So a little bit different in terms of outpatient psychiatrist. The role of the CL physician is mostly diagnosis, coordinating care with the other specialties, and then really transferring care to the outpatient psychiatrist. And the role of outpatient psychiatrist is to really focus on creating the behavioral plan and the treatment part. And that's it for me.
Thank you, Dr. Torbey. Okay, we're going to move on to physical therapy. Jenna, take it away.
Hi, my name is Jenna Werner, and I'm going to talk a little bit about the role of physical therapy when working with patients with FNSD. And go to the next slide. So overall, kind of really arcing back to what Dr. Torbey and Dr. Dean were talking about, we really are looking to improve function, and we are not going to really hyper focus on their impairments. We're going to kind of look more at a whole body function here and try and get people up and moving, because if we are kind of specifically, you know, asking them to kick their leg or doing manual muscle testing to assess their strength, we are likely going to get a different picture than if we say, hey, can you go stand up and like grab yourself a glass of water, something like that. We are also going to work really strongly with the rest of the collaborative team. We are a piece of the puzzle, but we really need everyone coming together, especially occupational therapy and behavioral therapy, for us to see the best outcomes. And we know, of course, that there is a strong overlap with FNSD and a variety of other psychological conditions such as anxiety and depression, and we know that exercise can be helpful for those. So we see the additional benefit that as we get these kids up and moving, that we can see some improvement with that, which can again play into them being more functional. Next slide. So when we're doing the evaluation, really the big thing that we're looking at is how are they moving? So we're taking an interview, we're trying to get a read on what they're doing at home, what they're doing at school. Are they participating in any extracurriculars, that kind of thing. And then what will they do for us when we see them in the clinic? So we are gonna assess their strength and their range of motion and their balance, but we're gonna do it more in, hey, let me see you stand up, let me see you roll over, and then we're gonna kind of see how they're able to use that strength and range of motion functionally. Some tests that we do look at sometimes is the lower extremity function scale, which is a self-report essentially on kind of how they're doing moving around, and we can sometimes see improvements in kind of their impression of their improvement and participation over time. 6-minute walk test is a great functional test in terms of endurance. And it's again another one that we can kind of just say, okay, let's go take a walk and see how, and we can see the distance. And timed up and go is a test where they stand up, walk a little bit, turn, and come sit down. Now that one is one where people generally know they're testing, so the results can be variable. But it is nice to have some concrete baselines just in terms of, you know, showing insurance that we are making progress, because insurance doesn't always look at participation as a goal that they're looking to see the progress on. They want to see something in these more concrete measures sometimes. So we do want to make sure that we have that, especially when someone is in, say, inpatient rehab. Next slide. So I'm going to talk now a little bit about kind of the overall strategies that we're going to look at for physical therapy. When occupational therapy talks, they're going to focus a little more on kind of the goal setting strategies that we also utilize in PT. So when we are working with someone, the first thing that we're kind of looking at right off the bat is how comfortable are they with movement. So sometimes movement just becomes something that's really scary for people. And so we're not gonna, we don't want to go from 0 to 100. We're gonna just really kind of figure out where they are. And then that's where we're gonna start. So what they can do is they can sit, then we're gonna work on things in sitting before we work on things in standing. And we wanna slowly introduce and slowly increase the amount of time that the demands we're putting on them in terms of movement, so that it doesn't become another traumatic or scary thing for them, but that they can kind of feel like they're in control of it, that they have an idea of how it's going to progress, and then also that they can have success throughout the process, because when we are successful in trying a new thing, then we are obviously more motivated to try the next thing. We're also going to take bigger activities such as walking or standing or climbing the stairs, and we're going to work on those in smaller pieces. So while we're doing those activities, maybe such as doing small step-ups or working on prolonged standing or working on sitting to standing, because that's going to use a lot of the same muscles as we use to build the stairs, we're going to do those little pieces. So while they are building strength to do that, they're also going to continue to improve their confidence with moving and improve their comfort. When we're doing these activities, again, it's still going to be a focus on more kind of functional movements, or, depending on the age of the kid and what they're into, we're going to work on making it something that they're motivated and interested in participating in. And that's going to help us build strength and build endurance. So we are going to be addressing those impairment level deficits, but we're not going to necessarily be like, all right, I want you to do 10 bridges, because a lot of the time with something like that, we'll see more of those responses that we would see like if we were doing specific testing, that they're not going to be able to do it for the testing. But if I did something else where I'm asking them to fire and strengthen their glutes, but it's fun and they're engaged in it, then they're more likely to be able to do it. And same thing with the neuromuscular re-education. So when we kind of are doing these bigger movements, that will kind of retrain that connection between their brain and their muscles to help them move in patterns that are going to be more effective when we get to the point that we can do things like walking and going up and down the stairs and running. Next slide. So as they get more confident, as they feel more comfortable, that's when we're going to start pushing the challenge and the duration and the intensity. And again, these are going to be gradual things. It's not going to be like, oh, good, today you walked around the block. Tomorrow we're going to go run a mile. We're going to slowly increase it. And it really depends on the kid and how they're doing in terms of how fast we can move that forward. But again, as we increase these things, we're going to increase their endurance, we're going to improve their strength, and we're going to improve that connection between their brain and their muscles, which is going to improve their activation and their power. Once we have kind of built up that basic strength and endurance, because some of these kids, they come in and maybe they've been in a wheelchair for several weeks or a month. And even though, as Dr. Dean was saying, they have those neurological connections between their brain and their muscles to fire them, they haven't been using them. And unfortunately, it really only takes about 2 days to start having muscle mass start to decline. And so you don't have to be inactive for that long to then feel the effects of it when you're trying to be active again. So once we've kind of built those building blocks and we have the strength, then we're going to start to try and walk more, try and do the stairs, try and get these kids outside. Additionally, if they've been using a wheelchair or a walker, or a cane or anything like that, we're gonna, as we've improved strength and balance and coordination, we're gonna start to try and wean off those devices as well. And that will also tie into them as they get more confident. Hopefully they won't kind of need that piece to make them feel safe. And during all of this, we are working really closely with the team, but especially as we start to increase the demands and increase the challenge, we want to make sure that we have good communication with psychology so that we can utilize those coping skills, because when things get harder, we know that they're going to need that extra support. Slide. And so once we've kind of got those basic skills in a safe space in the gym where they know the environment is controlled, then we are going to start working on taking those skills out into the community, because the truth is, of course, these kids are not going to live in the PT gym or the hospital, wherever they are doing this work. So we want them to kind of get used to using those skills with other people around. We want to work on being in varied surfaces and being outside, but that is another level that we're adding in. So really, when we're starting to work on all these things, we are going to do it in an environment that feels safe and an environment that feels controlled. And then once they feel confident and they feel like they have control of that skill, that's when we're going to take it out into the places where they're going to use it realistically in their life. And if they are now, so, you know, sometimes we're seeing people in an inpatient setting, sometimes we're seeing them in an outpatient setting. Once we are moving towards an outpatient setting or leaving inpatient, we're going to make sure that they have a comprehensive program of activities to do at home. And some of that is going to be to help them just remain active and maintain the strength and endurance that they've built. And some of that is just going to be to also just kind of keep them motivated and give them some of that structure that they've had while they were in therapy, to integrate that into their home and have them take some more ownership and autonomy of that. Additionally, we're going to make sure that we're working on making sure that they are kind of fully supported for whatever activities they want to do at home or at school. Do they want to go back to a sport? Do they want to, you know, what do we need to get them able to confidently get around their school building so they can do that without whatever supports they might have been needing? And a big piece of that is also training with the family and training with any other caregivers that are involved with them. I think that's it for me.
Great. Thanks, Jenna. Okay, we'll move on to Nicole now.
All right. So for occupational therapy, I will give kind of a brief overview and echoing everything that everyone has already said, so I won't go super in depth, because everything that you just kind of heard from Jenna, we're applying a lot of those same principles within our evaluation and our treatment sessions as well. Next slide. So the role of occupational therapy, we all know that FNSD can lead to a loss of independence and fulfillment of daily roles or our occupations. So as part of OT, we really work on looking at what are the specific domains that are impacting that function. Is it neuromuscular pieces? Are we looking at movement patterns? Are we looking at strength, our endurance? Are we looking at sensory functions, their ability to kind of detect and register certain sensory inputs, their awareness of their body position? Are we looking at mental functions, their cognitive flexibility, their coping, their ability to regulate kind of behaviors, their self-esteem, and their energy? So we're going to kind of take a look at those specific domains, how they're impacting function, and then how those kind of problems that we have with function and with our performance in daily living are just impacting our general living. We like to identify valued activities and important roles, especially in pediatrics, because it's just so important to motivating them to participate in therapy. OT really strives to just help individuals regain function, reintroduce their daily occupations, and reestablish routines. Next slide. During our evaluation, we're trying to develop an understanding of what the patient's daily routine is. So what does their typical day look like? What activities do they need assistance with? What activities are meaningful and motivating to them? How do their symptoms present? And how do their symptoms impact their function? What strategies do they already have to manage their symptoms? And what is their understanding of their diagnosis? Just so we kind of know where we're starting from. Next slide. Sometimes we will use standardized assessments, but they tend to be more subjective. So we'll use some Likert scale questionnaires completed by the patient. Often we have accompanying caregiver versions as well. So for OT, a lot of times we like to use the child and adolescent scales of participation or the functional disability inventory that both kind of look at, specific functional areas in the home, in the school, in the community. How do they, do the patients themselves perceive their participation in those areas? We'll also use semi-structured interviews to just kind of assess engagement in occupations and the patient's self-perception of their participation. So really involving them in setting those goals and getting an idea for where do they feel like they're at, so that we know where our starting point is. Next slide. For treatment, we're really focusing on participation and not on symptoms, just like Jenna had mentioned and everybody else beforehand has as well. We know that the perceived ability to complete daily activities often leads to an increase in confidence, in satisfaction, and in quality of life. And it's truly the catalyst to kind of returning to that full age-appropriate participation for our patients. We always say it doesn't have to be the biggest hurdle or, their huge overarching goal achieved in week 1 of therapy, but just participating in therapy, participating in a series of small activities will have a huge impact on their confidence in themselves and their engagement going forward. Some of our interventions tend to be task-specific practice for ADLs or IADLs. So these could include things like showering, dressing, meal preparation, household tasks, pet care. We work on kind of just going through, looking at the movement patterns, looking at ways that we can adapt things, looking at just practicing and gradually increasing their tolerance to completing these activities. And we look at kind of problem solving ways to be able to be more independent with these activities and then replicating that performance in the home environment. So really just breaking down these tasks, what are the barriers here, and how can we gradually work on those specific pieces to ultimately improve that function and that independence. We might look specifically at improving movement of upper extremities, lower extremities, standing tolerance, functional mobility, endurance. And in OT, thankfully, we get the joy of being able to tie everything into motivating leisure activities or functional activities. So that could be playing a game, that could be baking in the kitchen, that could be playing basketball outside. So we get to kind of tie all of these goals into the things that truly are motivating to our patients. And then we work a lot on application of coping and energy conservation strategies into functional activities. Next slide. So really just embedded in everything that we're doing throughout our sessions is a lot of education. So education, alongside the entire team, but really helping to drive home that message and that understanding of what is their FNSD, what is their body stress response, and what is its impact on their FNSD symptoms. What are those exacerbating or alleviating factors of their symptoms? How do different choices that they're making with their lifestyle, nutrition, sleep, or even just their environment in general, whether it's at home or at school, how is that impacting their symptoms? Where we spend a lot of time is really educating them on energy conservation strategies. So things that they can do to pace themselves, to plan ahead and really kind of understand the whole picture, so that they don't have that mentality of either I can do everything that I want to do in my day, or I'm not even going to try and kind of can't do any of it at all. So really helping to try to break things down, to slow things down, to think about, what are their anticipated challenges? If, one of their goals is social participation and being able to go to a movie with their friends, what are their, exacerbating factors? Where are the areas that they anticipate seeing challenges and seeing an increase in their symptoms? And how can we plan ahead for that? What are the things that they can kind of do in the moment? What are the strategies that they can use? What are things that they can do the day before or even earlier in their day that might kind of impact how much energy they have and how much bandwidth they have to kind of do this really big social activity or what they perceive as this really difficult activity? And then we work a lot on goal setting, tracking those goals, tracking progress, and readjusting our plan as needed, so that we're really starting to shift so that these patients can be a little bit more autonomous in that area. There's a lot of dependence, I feel like, sometimes with moving through the medical system and seeking a diagnosis for so long, that we're relying a lot on caregivers or on medical professionals to kind of move us forward. And especially where I'm at in kind of an outpatient day program, at discharge, we're really looking to see our patients be able to kind of take that role on themselves. So it's something that we're constantly practicing within sessions, and just really being able to apply a lot of the skills that they are learning within their behavior psychology sessions, their PT sessions, in psychiatry, across the entire board, and just applying them into these functional activities. I think that is everything.
Great. Thank you so much, Nicole. And finally, we are moving on to Karli to talk about the role of therapeutic recreation.
Hi, my name's Karli. I'm one of the recreational therapists in the inpatient unit, and I am part of the child life and therapeutic recreation department. Oh, sorry, I switched my slide myself. Can everyone see that okay?
Yes.
So just very simply put, recreational therapy is offered to all of the patients who are admitted on the inpatient unit for chronic pain. Recreational therapists use preferred activities like games, sports, arts, and crafts to recover and have fun while promoting new skills. So we have a playroom within our inpatient unit. We also call it the therapy center here at Kennedy Krieger, so I might switch that while I'm speaking. So we provide one-to-one sessions in the therapy center, structured groups. We provide opportunities for open play. We have special events, and we provide community outings. One thing that's unique about our program is our space is open 7 days a week, and we have programs offered in the evenings and the weekends. So unlike all the other traditional therapies that are offered here, we are really kind of here on the front lines 7 days a week on the evenings, similar to like our nursing staff. Next slide. Yeah, this one. So just to kind of talk about how we assess our patients. So recreational therapy isn't an insurance-driven therapy. So while the other therapists like PT and OT are kind of spending their first sessions doing those evals and assessments, we really get the opportunity to spend our first couple sessions with our patients doing things like building rapport, just kind of helping them acclimate to the hospital, being in the hospital, and getting to know them. What do they like to do? How are they motivated? What keeps them engaged? And oftentimes, I'm sure you guys hear lots of things about why they can't participate in activities anymore. So I wanted to talk about typical barriers to participation in leisure activities. Obviously, the physical symptoms, fatigue, pain, psychological factors. Again, mentioning I used to do this, but I don't do this anymore. A lot of those social things, social avoidance, worries about peer acceptance. And then a couple other things are community accessibility and family dynamics. Next slide. Some common recreational therapy interventions and goals that we're doing with the patients. So we do arts, crafts, and music-based activities, or movement-based activities. All of those activities are targeting expressing and regulating emotions, providing distraction through activities, improving physical functioning, coordination, strength. One thing that's really kind of cool about recreational therapy is, although we are considered a therapy that is required for our patients to participate in, we're not always viewed as a traditional therapy. So we often see patients show skills within our space and within our sessions that they might not necessarily show while in the gym and physical therapy. We provide structured peer groups, which promote the social interaction and communication skills. We do leisure education to explore new interests or research activities for discharge to support ongoing progress. And then kind of what Jenna mentioned, one of our big things is community reintegration outings. So this is our opportunity to assess everything that the patients are learning in rehab. So integrating, see how they integrate and apply all of their skills that they've learned while they're here. Next slide. One thing that's kind of unique here is we have something called independent privileges. That is a privilege that is given to patients that the team deems appropriate, and the patients are expected to know their daily therapy schedule, go get themselves to and from each therapy, walking by themselves. And then in addition, outside of their therapies like PT, OT, behavior psychology, they are required to go to our therapy center and participate in independent activities. So that could be even as something as simple as like advocating for themselves to get their supplies, moving around the environment to get what they need, and also just participating in the activity. I think OT talked about activity pacing. So a lot of times behavioral psychology will do some education on activity pacing, and then we have the ability to incorporate it into the routines and preferred activities. One thing that I didn't touch on in our in an earlier bullet is because I work in the inpatient setting, we really have the ability to control their routines and structure their day. So rec therapy is a great way to also continue that routine and structured engagement. Another thing we do is provide co-treatments with other therapies that kind of just increases engagement, participation, and compliance. I can remember specifically going with Jenna and walking to Starbucks with a patient, and then lots and lots and lots of positive reinforcement. We are kind of interacting with these patients all day in between their therapies, encouraging their efforts, telling them they're doing a great job, and we really just want to help them have a normalized, fun experience while also promoting their functioning. Next slide. How does rec therapy work with the multidisciplinary team? So we are kind of constantly communicating with each other within the inpatient setting. We're talking on Mondays, we're talking on Wednesdays, and we're talking on Fridays. Like I mentioned before, recreation therapy is one of the couple disciplines that provide services 7 days a week in the evenings. So on Fridays, we meet as a team to kind of come up with a plan to support continued carryover of their goals. And then rec therapy is kind of the discipline that would provide an update at the end of the weekend. Therapists provide goals for community outings. And then, like I mentioned, rec therapy updates on progress within the community setting. So we really are we really get to see the true presentation of these patients within the community. And then, like I mentioned, co-treatments. Next slide. How do we work with caregivers? We involve caregivers in our recreational therapy sessions. So whether that is kind of simulating what maybe like a family game night would be like, or how to encourage your child to participate in their interests, we'll be kind of modeling those interactions with the parents, reinforcing the skills that they're learning with psychology. And then we also have parents join us on community outings. We typically like to have an outing first without the caregivers, kind of just to assess what their presentation is like within the community. And then the caregivers will join our second outing so that they can carry over and apply the skills that they've learned during training. Next slide. And these are just some pictures of some of our patients participating in different activities. We have pottery painting, we're at the zoo, they're doing a obstacle course, they're baking. So our patients are really active and they're doing things all the time. That's it.
Thank you, Karli. I'm going to ask all of the panelists if you all can turn your cameras back on. I know we're a little short on time, so we might just really quickly kind of go over case, and then if people have a couple extra minutes, we can say and answer some of the questions. I know a couple we were able to provide some resources in the chat. So really briefly, we just wanted to share a little bit about Jane, who is a 14-year-old cisgender female with past history of migraines, also anxiety, depression, who began experiencing functional seizures several weeks after sustaining a concussion. Those functional seizures presented as full body tremors, sometimes with loss of consciousness, sometimes without. There was kind of crying, choking, and gagging that happened during them, and speech difficulties after. Other symptoms included dizziness, nausea, visual disturbances, weakness, headache, tremors, numbness, tingling, challenges with sleep, sensory sensitivities. So Jane presented to our outpatient multidisciplinary clinic. She was using a wheelchair. She was not able to consistently use her upper extremities. She had challenges with self-feeding and completing self-hygiene tasks. She had not been attending school in person or virtually, was meeting some with a teacher at home, but really had challenges engaging in academic tasks. She was wearing sunglasses most of the day due to photophobia. She had stopped participating in sports like volleyball and soccer. She was someone who enjoyed cooking and baking and hadn't done that. Someone who was into making TikTok videos, but had really stopped that, and really just wasn't seeing friends or spending time with them at all. So we saw Jane in our multidisciplinary clinic and referred her to our inpatient rehab program. So she did our inpatient program and then stepped down to our intensive outpatient rehab program, where she continued to make progress. So just to kind of like orient everyone, when she first admitted to our inpatient program, she struggled a little bit. She, I think, was pretty anxious about being there and kind of worried about like what it was going to look like. How long am I going to be here? How am I going to know, when I can go home? I don't really want to be here anymore. Thankfully, her parents were huge advocates for her, like continuing to stay and push through. They really felt like, hey, we think this is what she needs, this intensive push, and we're here to do what the team recommends. So we started off by just kind of, as a team, coming up with some really specific, tangible goals for her that she kind of worked to identify, and creating a list of like, here are the goals of what we want to work on. And that included things like fading out her use of sunglasses. So we set goals of like how many hours a day she was going to wear, and we gradually faded them out. We implemented a positive reinforcement system. So as she, was working through her goals, her reinforcement that she was going to earn at the end was having a Starbucks party. We did a lot of co-treatments in sessions. So I want to talk a little bit, maybe Jenna and Nicole can share a little bit about kind of some of the strategies from PT and OT standpoint to kind of address some of the challenges with walking and with ADLs.
Sure, I can talk about that just really briefly. So she, when she came in, she was in a wheelchair. She was not walking and hadn't walked, I believe, for several months. But she was someone who did really well utilizing distraction. So when she was doing something that was fun and that she wanted to do, she was much more engaged. So we did a lot of card games. We watched a lot of makeup tutorials. And then as she got more motivated, she was willing to, walk to go get the thing that she wanted, or walk to play a game or that kind of thing. And she also, once she started moving a little bit more, she was very competitive, and so she was really motivated by like a ring toss or something like that, where she could win. Nicole, did you want to talk?
Sure. Yeah. So for occupational therapy, we did a lot of baking. She loved cooking and baking. It was a great way to be able to kind of work on progressing some of her like functional mobility, looking at her doing a lot of things standing at like a countertop level where she had like a little bit of support, but also still had to figure out like, how do I manage the movement from the countertop to the fridge? Or how do I manage this while I'm also holding something in one hand? So kind of having those distracting pieces or having kind of the requirements of the task lend itself more towards her progressing her mobility away from like using a walker and kind of away from using those supports, and kind of really working on her strength and endurance. Within those activities, we were also able to work a lot on just those pacing and energy conservation strategies. So how do we take this activity? I know, she had brought in recipes from her family that she really wanted to try. So how do we kind of take these big recipes that might seem super complex or have a lot of steps to them, and how do we break that task down? How do we switch between standing and sitting? How do we think about how she could do this at home? So how do we use different devices to kind of make things easier for us, and different kind of kitchen appliances that are going to be less tiring? Do we sit there whisking frosting by hand, or do we use a hand mixer, or do we decide at the store that we're just going to buy it instead of making it homemade? And kind of where are our priorities, and where can we adjust the way that we're doing things so that instead of this task being something that's incredibly difficult to achieve, we can kind of break that down into smaller steps. We're also able to kind of integrate a lot of community-based activities. So taking trips to the grocery store to be able to kind of get out in the community and like, okay, so if our big goal is to be able to make this item, then, we also have to do X, Y, and Z beforehand. So kind of using that as that motivating factor, to kind of address and tackle some of the more challenging things as well.
Awesome. Thanks so much. I think it's really helpful to kind of hear how to kind of put some of these things that you all talked about kind of into practice. Karli, I know something that we had talked about that with Jean, she had been having functional seizures kind of primarily in the evenings. And so when she first admitted, as Karli was talking about, oftentimes in the evenings, we want our teens and young adults to get down to the therapy center. And she really didn't want to go because she was really worried about having a functional seizure in the therapy center. And what are other people going to think about me? And what am I going to do? And so we really kind of prepped for that and worked through some of that anxiety, and got to a point where like, hey, why don't we just try it? Why don't we go and see what happens? And I remember kind of hearing the next day, or I can't remember, it was like a weekend, whenever I saw her next, that she decided she was going to go to the therapy center, and she didn't have a functional seizure in that setting. So I wonder if you can kind of talk through some of the things that you kind of did, the team did with her to kind of help keep her engaged and participate there.
Yeah, so I have very vivid memories even of her first night, and trying to get her to come down, and her crying with her mom. And one thing that's unique about our program also is that the caregivers leave our patients after our assessments and all that. So I think we, especially like rec therapy, gets the opportunity to really like meet the parent, because they know that we're going to be the ones that are really going to be interacting with the patients the most during the day. So she came down. I think another thing that's unique about our program is we integrate the patients here for chronic pain in groups and within our therapy center with patients who are here for under all the rehab services. So they're participating in activities with groups of peers that really have all different abilities and really all look different. So, she might be worried about having an NES episode, where one of the other patients might be worried about using, I don't know, their communication device in the therapy center around peers. So we, with lots and lots of encouragement, she came down. We got working on activities right away. She did really well being distracted by games, arts and crafts. She also actually really enjoyed working with the younger patients. So she liked to be given like a task to kind of help us, which is nice because that is really working on all of her skills. But we kind of do like scaffolding through activities. So maybe the first sessions will start out by like a recreational therapist planning the activity based on their interests, and we'll kind of do it together. And then, get that buy-in, get that motivation, and then maybe they'll be more willing to initiate it and start it on their own at a later time. And then the carryover to independence. So we are just really working on that initiation and independence during those activities.
Thanks so much, Karli. Sorry, I wonder if you could just, I know you have to head out, and I know there are other people need to leave, so feel free. We'll kind of chat for a couple more minutes. Sorry, if you maybe want to chat a little bit from like a medication management standpoint. I know she had a lot of anxiety and mood concerns, kind of what your recommendations were from that standpoint.
Yeah, so a lot of times when we're evaluating patients with anxiety and functional neurologic symptom disorder, we tend to sometimes I'm just going to talk in general a little bit, because a lot of the patients that present to us, part of the challenging part of our role is there's a little bit of resistance towards if we bring up some of the psychiatric symptoms, there's a misconception that we're attributing everything that's occurring to the psychiatric symptoms. So I think that that's partly also, I just wanted to kind of bring it up, is making sure that we reinforce, part of our role is reinforcing that because you have anxiety, it doesn't mean that your symptoms are because of your anxiety. Because you have depression doesn't mean that this is what's causing your functional neurologic symptom disorder. So really reinforcing the part that those two are separate, and spending some time talking about the biopsychosocial approach in terms of like the relationship versus like the causation, which is in my experience tends to be where the patient and the family's mind goes to. So we do spend a lot of time for that. So that is part of the treatment plan. From a medication standpoint, we also sometimes face some resistance in regards to starting medication, and patients not wanting to they really want to focus on the physical symptoms, and in their mind, maybe if my physical symptoms get better, then my everything else is going to get better. And obviously, if you have a longstanding history of generalized anxiety disorder, you really need to treat that separately. And I spend some time with patients reinforcing that the research emphasizes the combination treatment. And so if patients do have significant psychiatric comorbidities like depression or anxiety, I do reinforce starting medication like an SSRI, which is what we did for Jane. Yep.
Great, thank you. In the interest of time, I did want to address some of the questions that people had. I know there was a question about inpatient treatment programs and kind of where you send people for multidisciplinary approach. So there, and there's a question, is it a med psych? I think it does vary based on kind of what the presenting concerns are. Some patients do really well in an intensive rehabilitation program. Some patients may really need more of a med psych program. And I think a lot of that is dependent on the psychiatric complexity and those comorbidities. And so I know in our clinic, that's one of the things that we're doing when families are interested in intensive programs, in addition to looking at whether or not they have enough, PT and OT goals for a rehab admission, but also, we don't expect that people are going to have zero anxiety or depression symptoms, right? But kind of to, if they have psychiatric comorbidities, how, kind of what is their, level of those comorbidities? Are they having active suicidal ideation or self-harm? Oftentimes those patients are not appropriate for inpatient rehabilitation or intensive outpatient rehabilitation and may do better in a med psych program, or if there really are a lot more of those psychiatric complexities, then sometimes patients may do better in a med psych program than an inpatient rehabilitation program. So at least here at Kennedy Krieger, that's part of what we're doing in our multi-D FNSD clinic is trying to kind of parse apart what things are looking like, whether there are enough rehab goals, and if things are stable enough from a psychiatric standpoint, knowing that sometimes the psychiatric symptoms get exacerbated in the rehab setting. And so we want to make sure we've kind of got enough stability there. I put the link in. The FNSD SIG has worked to compile a list of treatment programs. So encourage anyone who's looking for treatment programs to visit the SIG website. Also, if you are part of a treatment program and you are not on our list, please let us know. We are continuing to add to that list. So encourage you all to reach out to us. I know there was also a question about the kind of clinical pathway piece, which Dr. Torbey, I think you had kind of put some information in the chat about that. I don't know if you have a minute to kind of
Yeah,
talk
there
about
were a
that.
couple questions about it. So I did put the link for the paper. I really can't reinforce how wonderful that paper is. It really creates a framework for anyone who is working with these patients, especially across the continuum of care. If you're on the consult service and even on the outpatient setting, because it has all the scripts. Someone asked about the scripts. If you go, download the article, there are a lot of different scripts for different things. Like it has a script, for example, for how to discuss measures with the patients, a script for discussing the diagnosis, a script for discussing any extra tests that you want to order. Really a wonderful resource. The other question was, how do you convince specialists to spend the time on this? I had a conversation with the head of our consult service, and in her opinion, sometimes when a case goes wrong, it tends to really help a lot, because patients tend to stay there longer, and there's a prolonged length of stay. Parents are disgruntled, they're unhappy, they really when the communication of the diagnosis is not done in a tactful manner, there's a lot of resistance. They're pushing for more tests. They're having a hard time getting discharged. So it tends to actually, I mean, that's not what we want, but sometimes that could be what drives the primary team to put in the extra effort in this. But on our service, we really reinforce that pediatric residents and neurology residents rotate with us, actually. So they tend to actually pass on our service, and we spend a lot of time in psychoeducation and the importance of the multidisciplinary work. So that's what we do at Johns Hopkins, and that really helps.
I also think perspective, it really is worth it to find the right team to do this, and to find neurologists who want to do this, because this is a different skill set than dealing with strokes or dealing with other things. This explaining is its own skill set, and some neurologists, that's not really the kind of work that they want to do. And the other thing is, even if you're someone who's pretty good at this kind of thing, if you're getting paged about 3 patients who are stroking out and 4 patients that are in status epilepticus, it's really hard to also give these patients the kind of focused attention they need to set them up for success. So I have 90-minute appointment slots with these patients, and part of the reason, and 2 hours if I'm paired with psychiatry. So part of the reason we can do this is because I'm given the time to do this. In terms of finding a neurologist who's interested in this, the groups that interact with these patients the most are movement disorder specialists, because of functional tics, and because movement disorders in general, there's often no lesion. So when people are nervous that they're missing something and that it's not FND, they're often sending them to movement disorder specialists, epileptologists, because seizure-like attacks are one of the most common manifestations of the disorder, and headache specialists, because a lot of these patients have chronic pain. So that's where you're going to find the person who actually would like to do this work if they were given the time to do so, and then getting your facility to commit to letting them do that is the next piece.
Well, thank you all so much for sharing your time today. I'm sorry we went over, but hopefully this helped to kind of give people a little bit of a picture of what it's like to kind of work in a multidisciplinary team. And, we really appreciate all of your time today, Karli and Jenna and Shannon and Nicole and Souraya. For those of you who are still here, this was recorded. The recording will be sent out. It usually takes about a day or two to everyone who registered, but we will also post it on our FNSD SIG website. So thank you again. There'll also be a brief survey that goes along with the recording. If you don't mind taking a minute to answer that, it helps us kind of planning webinars moving forward. And as I mentioned before, if you haven't had a chance to visit our FNSD SIG website, please do so. There's a ton of resources on there for clinicians, for families. There's that list of treatment programs. There's lists of training programs. So we really appreciate you all taking the time today. Hope everyone has a great rest of their afternoon. Thanks, everyone.
Thank you.
Thanks. Bye-bye.